Hey guys, just a quick diabetes case and review. This is a example that I wanted to share with you guys. It actually happened to me. This was a few years ago now, but this was back in 2015, and I had an 88-year-old female come into the emergency department because her insulin pump malfunctioned. So what do people do when insulin pumps malfunction? Well, the first thing they do is they ask pharmacy what to do, and we kind of throw up our hands because we don't really deal with them either. So it's sort of a interesting situation because I don't think it's really widely taught what you do with an insulin pump, but just some information for you guys in case you happen to run into a case with a malfunction pump or a pump you need to interrogate or something like that. Some things to know is, first of all, I would recommend understanding how your site works, and if you have access to a diabetes educator or a diabetes specialist or something like that that can come down and review it, because those people are invaluable in cases like this. But if you have access to a medical record, you should be able to find what pump settings there. So for example, I went into this patient's chart and I found that a month ago she had a chart or a clinic visit, office visit, and they put in all of her pump information. So her pump type, what type of insulin. So she's using Humalog here, which is insulin Lispro, and the rates there. So you can see her basal rate changes kind of throughout the day. Insulin to carbohydrate ratio, 1 unit per 23 grams of carbohydrates at 24 hours. Insulin sensitivities there, target blood glucoses are there, active insulin, and then kind of the plus or minuses there, percentage of basal and bolus. So it really gives you all the information. And so with that, you can kind of see, TDD stands for total daily dose. So that's how much insulin she's getting on a daily basis, about 18.8 units plus or minus, a unit. So that's really helpful information when you have a patient who comes in and they have a pump that's malfunctioned and you want to know, first of all, like, how much insulin do I need to replace on this person in the meantime before they can get their pump repaired? Medtronic's pretty good about sending new pumps pretty quickly, but you do sometimes have a window of time where you need to supplement with something else. So one thing I would say is the first question you should probably ask yourself is, why is she on a pump? It might be, you might think, well, she's of course a type 1 diabetic. And in fact, in this case, this patient was actually a type 2 diabetic patient who was managed quite well with just a small amount of insulin a day. And instead of doing regular injections, she elected to do an infusion pump. So while it's more common to see a continuous infusion pump on a type 1 diabetic, you can certainly use them in type 2 patients. So that's a really important thing to think about as well. What can she go without? Obviously, a type 1 patient would certainly need some sort of intensive regimen to back up their lack of pump. But a patient who is type 2 could get by with maybe some other options. So we talked about a lot of different solutions. I worked with her physician in the emergency department. We talked through, do we do a sliding scale mealtime? Do we do a basal? And we we're kind of working up a couple different rates. And eventually we came to two choices. We had the easy choice, which was, let's just give her some basal insulin. Let's give her, 10 units of Lantus or 15 units of Lantus, or I don't remember what we ended up doing, a day, and then call it good, and then have her follow up with getting a new pump in the next week. I believe this was, of course, on a Friday night or Saturday morning, right? So it's something where business hours aren't going to apply, and she can't just go and get a new pump very easily, or at least she might not be able to get one until Monday when it can be delivered to her house or picked up from somewhere. So that's actually what we elected to do. Now, you could certainly get a little more complicated and do a mealtime, but then you have to calculate sliding scales and educate the patient. The patient's used to using a pump. She's 88, so does she, how long has she been using the pump? Does she, remember how to do all the things? I'm not just saying that because she's 88, but in general, like, I think me personally, if I'd been using a pump for 5-10 years and somebody told me that I had to go back to sliding scale and carb counting, I'd probably be like, no thanks. But of course, you have to do some of that anyway with a pump, but with the individual injections, it's just so much more complicated, and there's so much more preparation and things like that. So it's a lot more work. So for an easy solution for this patient, I think we made the right choice by just giving her some basal insulin for the next couple days. We gave her a Glargine pen or a Lantus pen and discharged her from the ER. We did consult with our diabetes educator on site as well. Other scenarios. So if her blood glucose was over 500 upon admission, it wasn't in this case. She was actually pretty well controlled for the most part. But if she was looking at like a high elevated blood glucose, you would either think maybe DKA or HHS, and then you're going to go down a more advanced treatment algorithm and decide whether or not you need to give IV insulin. Which, remember, IV insulin, the only insulin we can give IV, at least that's well studied, is regular insulin. So in those patients, you'd maybe consider an IV bolus of regular insulin, maybe starting her on an insulin drip, and then admitting her to the hospital. We have something, and I'm going to talk about this a little bit more with critical care and emergency medicine in the summer, but we have something we call EndoTool, which is I think endo short for endocrine, not endoscopy. I always think about that when I hear that for some reason. But it's called EndoTool. And basically, as a provider, all you have to do is order EndoTool, and then it's all nursing run protocols. So it has all your lab checks in there. It has your insulin. It also has your dextrose boluses in case you need to, compensate. And we've actually found really successful management with that. It's all protocol driven based on labs and data and stuff like that. So from a provider standpoint, it's pretty easy. It's like ordering a heparin protocol. You just sort of order it and then you can kind of watch from a distance. If she couldn't get her new pump for 2 weeks, I would say that's probably a situation where, first of all, you want to have her follow up with primary care as soon as you can to see what would be the best option for her. Do they want to go with a more intensive insulin regimen for those 2 weeks versus just the simple basal that we prescribed her? All right, a couple of review questions. This one is the first question here. Which of the following medication regimens would be preferred to start in a newly diagnosed type 1 diabetic patient? And what other information would you want to know? That's more of a rhetorical question, but let's focus on the multiple choice aspect. So I'll give you a second if you want to pause or whatever and think about it. So, of course, hopefully this one, the newly diagnosed type 1 diabetic, rings a bell that you have to use insulin. So glargine plus aspart gives you your long-acting plus your mealtime. Every other option here is just for includes something that's only for type 2 diabetes, right? So metformin isn't for type 1, and GLP, in this case exenatide, is not for type 1 diabetics, type 2 only. Second question, we've got MT, a 46-year-old male. He's got hypertension and type 2 diabetes. He's been diagnosed recently and started on metformin. Additionally, he has been working on improving his diet and exercising more. After 5 months of these changes, his A1C is 8.7. What would be the best option today? You got, again, if you want to pause or something, but you've got 4 choices here. And first of all, knowing A1C goals, I'd say have a good idea. I'd give you if I give you an A1C, it should be pretty obvious, or I'll just tell you it's in goal or out of goal. But you should be able to know, I think, right off the bat, if I gave you an A1C of 10, that's pretty high, or if I gave you an A1C of 6, that's in range. So know those extremes. I won't kind of test you on those weird middle ground ones between the guidelines where they disagree. But best option here. So he's on metformin. He's working on his diet, exercising more. So those are kind of the key points here. So what's the best one? So A1C isn't at goal, right? 8.7 is still pretty high. All these options are technically okay. So this kind of comes into play, and this wouldn't be a question I would ask you on the test. I would give you a little bit more than this. But for discussion purposes, what more information would you want to know? Adding basal insulin would be an option, certainly, and that's something that, again, historically has been a choice that's been second line. But again, the endocrinology group decided that that's not the best choice anymore. For a younger guy, he's 46. I didn't give you any information to say he's got renal insufficiency. I would say if his insurance covers it, canagliflozin or one of your SGLT2 would be probably one of the best options to consider. First of all, it's got some cardiovascular related benefits potentially. It also has some weight loss associated with it. And assuming his kidneys work fine, it's a nice option to add second line. Now, it is expensive, so whether or not insurance can pay for it or not is a great question, but that's probably the way I would go with it. Now, again, insurance might say, nope, we want you to try glipizide first. And the ADA would say glipizide's fine too. And I personally don't have a big issue with somebody prescribing glipizide, just, using this question as a discussion point to say, what do the guidelines say and what's different, and to get you in the mindset of thinking about these drugs as all being acceptable options for the most part, but deciding which one's best for the patient. So in this case, I think B's probably the best because he's younger. If I gave you he had renal insufficiency, then you probably would think of insulin or glipizide, or renal insufficiency plus he refuses any injectables, then that takes you right to glipizide. All right. That's the last question. The cases are posted. Feel free to go through those and email me any questions you have. Thanks.